Good evening, everyone. I'm Dr. Srini Edaklaun, Chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. I welcome you all to this a different type of CME program from Kerala Society of Ophthalmic Surgeons. How I came to this program was like I went for a meeting at Goa, ISCRIS meeting, and there I met Dr. Ameya. So Dr. Ameya said, I was just talking about different surgeries and different practice patterns and all. So he was just telling that he has a huge practice. So there were a lot of dogs on the road. Then he said, so I have a passion for dogs and I love these dogs, and I'm presently performing a lot of surgeries on dogs, and he has a huge clientele from 3 different districts. So I said, then we'll have a program, because I'm not heard anyone really talk on these sort of. Say, I've heard Dr. Mahadevan from RA when he was in RA Trivandrum. We had gone and operated on a lion, and so that is one thing that I have heard about cataract surgery in animals. So this was very interesting, and he says like these owners are really attached to these dogs, and they love them as they love any of their family members. And so this I thought is a very, very important topic which should be discussed among ophthalmologists, and that is why that was the start of this program. And then I thought, okay, we should have, this is an offbeat talk, so I should have other offbeat talks. So Dr. Tejas Shah was also there, and he said, Srini, I'll talk on different things that other than cataract surgery that an eye surgeon can do. I said, sir, we'll have you along with Ame in the program. And then I thought, like, I've heard Dr. Shibu Varki is a prolific cataract surgeon from South India, and I've heard him speak on cosmetic eye color change surgery. So I thought I'll club all these 3 into a single program, alternative surgical practice for an ophthalmologist. And so that is how this program got the shape of what it is there now. And so KSOS has been doing a lot of scientific committee CME programs over the past 1.5 years, and our programs have very good viewership. Like the last one that I've done, and it's still continuing. I'll have one more episode of that. That's on cataract surgery training opportunities in different institutions across India. So I started with Arvind, RPC, so everywhere. So I'll have the 4th episode on 22nd with PGH Chandigarh, Westlands, Bangalore. So many other hospitals will be there. And so the 3rd episode of the same program has already crossed 3,000 views, which is quite a good viewership for a scientific program. So we will start our program today with the talk by Dr. Ameya Kulkarni, who is a consultant cataract refractive surgeon at Dr. Anil Kulkarni Eye Hospital, Miraj. He's an ex-lecturer, Department of Ophthalmology, Bharati Medical College, Sangli, and is a member of Management Committee of Maharashtra Ophthalmological Society. He is a dog fanatic since 1984, and which is really, I could see that in his eyes when we went for the walk, and we saw a lot of dogs on the road. And it would be great to hear from you, Dr. Ameya, about how you do surgery on these dogs, about the anesthesia, your IOL choices, and the post-operative regimen, all this. Dr. Ameya, please take over.
Thank you, Dr. Srini. It's quite a pleasure and honor to be here and to be invited for this particular talk. I had never imagined I would give a talk like this at a forum this big that Dr. Srini is providing. I remember we'd been in Goa, and because I don't drink and Dr. Srini had just arrived, we were the only 2 people who were awake at that time in Goa. So we went for a walk. And this is how it came to be. We just talked on dogs, and he was very excited when I said the dogs have been one of best patients I have, because I am very happy treating the dogs that are there. And he was very excited about what you do, how you do. And in that meeting itself, 3-4 people approached me. Okay, we just heard from Dr. Srini that you operate on dogs. So what is to be done? So we decided we'll have a separate session for this. So I think I've hyped this enough. So let's get into the nitty-gritties of it. Okay. Is my screen visible?
Yes, Amaya.
Yeah.
Visible.
Okay. So this is about canine cataract surgery. Let's get into it. So why is there a need to do these surgeries? So apart from the personal reason that I'll get into, there are about, the last count, it is estimated that there are 31 million pet dogs in 2023. Then these are the registered pet dogs. We're not talking about dogs that are not registered. And to cater to all the animals in India, we have around 70,000 veterinary doctors to cater to all the animals. And in India, you will realize that basically all our veterinary training, either there is a lack of training in surgical aspect of veterinary medicine, or it's all directed towards livestock. The farm animals that actually give you it makes economic sense to treat them. It's all directed towards livestock. There's very little lack of infrastructure in veterinary institutions. So that is why I think we should be doing this. On a personal note, I had seen my father operate on our dog 20 years back, and that kind of is still in my head. He was the first one who showed me phaco could be done. And once I came back from my training, it was my mother who inspired me. She's a dog lover, inspired me to start this. So this is still a hobby. I do it once a month. We collect all the cases that are there, and we operate once a month. And how, let's get into the how. So there is an extensive pre-operative preparation. You need general anesthesia. We do only phacoemulsification. And more importantly, there's something called canine IOLs. We'll get into it one by one. Pre-operatively, yes, slit lamp examination and IOP. Now, how do you do slit lamp examination on a dog? So this was my first problem, how to do slit lamp examination. There once happened a case wherein the dog was posted for surgery. After we took the dog under microscope, we realized that most of the opacity was on the cornea and not the lens. So it so happens that dogs are not very cooperative patients. So slit lamp, we use the slit lamp, that the portable slit lamps are available. It suddenly hit me that we have those portable slit lamps for our camp activities. So portable slit lamps can be used. And why specifically intraocular pressure? Because these dogs, the elder dogs that are there, these are very vulnerable to glaucomas. So you have to be very careful before you decide to operate on the dog. So how do you take IOP? So I had to, against the wishes of so many people in my hospital, dedicate a tono pen for the dog. So we do take IOP with a tono pen. Pre-operatively, you also need to shave the fur around the orbit, because when you're draping, your plastic drape has to stick there, and there is a lot of fur around the orbit which can actually come while, in between while you're operating. That in itself can cause problems intraoperatively. So topical medications, we start the dogs on antibiotic steroid combination 48 hours prior, NSAIDs 2 hours prior, and Midriatics. Topicamide is enough 30 minutes prior to surgery. Why start the dog on antibiotic steroid combination 48 hours prior is these dogs are extremely vulnerable to inflammation. They have a very strong immune system. So the inflammation starts right on table. So if you need to control that inflammation, you need that antibiotic steroid coverage before we start surgery. NSAIDs topical, you should never give NSAIDs on your own orally. Human NSAIDs that are available are not very conducive to the dog kidneys. So topical NSAIDs and Midriatics, topicamide 30 minutes prior to surgery. Anesthesia, it is recommended that you give halogen anesthesia, but We don't have any anesthetists in my area who can intubate a dog. So we have settled on ketamine anesthesia. It works very well. More importantly, in anesthesia is the consent. Now, the issue here is it's always an elderly dog. There are issues. These are exotic breeds that come to you. They have a lot of problems with their hearts, their kidneys by the time they come to you. So it's absolutely essential that you take consent from the owners. And you have to take a death consent actually. There could be a death on table. The dog might not survive the surgery, survive the anesthesia to be very specific, not the surgery. That consent is absolutely essential. The details of the anesthesia, I generally leave it to my veterinary doctors. They are very capable of giving good anesthesia, and you don't really require intubation in these dogs even to do cataract surgeries. So there's a short video. Now, this is not my video. I have not yet set up recording for my cases. So this is a video I got off from YouTube. So it shows all the steps very well. What are the points that we need to do differently? That is what I'm going to talk about. Now, there's a vestigial third eyelid in dogs. It is not as functional as in reptiles or as in the avian species that we have, but there is a significant third eyelid that needs to be properly taken care of. You have to put your speculum beneath the third eyelid and make sure everything is clear. The another thing which is important that you saw here, all your incisions have to be clear corneal. Now, why this is because any time if you touch the iris, it starts to get the inflammation cascade. You can actually see the fibrinous material of the inflammation right on table. It is that fulminant inflammation that dogs can have. So it has to be clear corneal. You should never go anywhere near the iris. And CCC needs forceps. CCC needs forceps because I think generally the anterior capsule I read is about 2.5 times thicker in dogs than in humans. So plain cystotome will not work. Whatever we do, the plain cystotome does not work. I've tried, it needs a forceps. Now, another thing is these are white hard cataracts. We have a subconscious relationship that if you see a full white cataract, it's going to be a very soft cataract. Everything will come out really easily. Doesn't happen in dogs. It's a hard cataract. It's a very large lens. You can see in the video. It's a large lens and it's a hard cataract. So you have to actually operate like you're operating our grade 3, grade 4 cataracts. And you can see as the cataract starts to be taken care of, there is a green reflex behind that comes from the retina. There's no red reflex. This green reflex is basically the retinal pigment epithelium in dogs, which is about 200 times more sensitive to light than the human retinal pigment epithelium. So this is the difference that you see. There's a CCC, and rest of the steps you don't have to really worry about. They are the same as we do in humans. And this is a lens that has to be put canine IOLs. We will talk about canine IOLs. Now, the IOL here is a very high-end IOL. This basically is from Bausch & Lomb. Bausch & Lomb are pioneers in canine IOLs. Unfortunately, Bausch & Lomb do not apply for any kind of certification in India. So officially, they are not available in India. Canine IOLs from these companies are not available in India. So you can see the rest of the stuff is all same. It's important that you take an absorbable suture at the end of surgery to your main wound. That's because the consistency of the sclera is it's the same as if you're operating a pediatric case, wherein it won't stay without the suture. It should not. So you have to take a suture at the end of surgery. And yes, subconjunctival steroids have to be given. Given the propensity of the dog eye to go into inflammation even post-op and even after you've done a very good surgery. Talking about IOLs. So IOLs basically the diopters. Now there are papers published that the dioptric power required for any dog ranges from about 40 diopters to 42 diopters. It depends on the kind of company IOL that you're using. So the optical diameter is slightly larger than that in humans. It's generally the ones I use is 7 millimeters, and these are all spheric IOLs. actually, technically speaking, the size of the IOL should be considered according to the size of the dog. So larger the dog, larger is the IOL that is required. These are some of the photographs that I have. This is a Rottweiler that we operated. I think this is after Dr. Srini told me. So I've not set up the recording yet, but this is these are the photographs that we actually took while operating. So post-operatively, what is to be done? This is the most important thing, e-collar. This is also called Elizabethan collar, which needs to be put on the dog so that they don't scratch their eyes. Topical drops, antibiotic steroid combination hourly for a week, and atropine, it can be eye drops twice daily for a week. This is absolutely essential, and the owner has to take responsibility of taking care of the post-op requirements, because there can be fulminant inflammation. It's called lens-induced uveitis in dogs. The whatever lens protein is exposed during surgery, that in itself can cause a lot of fulminant reaction. Many people, I think, have tried before doing dog surgeries. The basic problem was people used to try doing ECC and inadvertently touch the uvea, or not properly administer post-operative drops. So phacoemulsification becomes mandatory in these with a good post-operative regimen. So first day follow-up, what we tend to do is the IOP rise in dogs. The dog cannot complain that there's pain in the eye. So you have to check for the IOP day one, because there might be some retained viscoelastics. It's a large anterior chamber, so you need to put a lot of viscoelastic to get the desired results than what we are actually used to in daily surgeries. So IOP measurement becomes of paramount importance on day one. After the day one, everything is fine, the eye is quiet. We generally call the patient on day 15 and then day 30, and we've not had any issues afterwards. So what are our learnings from these? So OT infrastructure needs to be on par. This is actually very important, that we don't treat it as it's just a veterinary surgery. So why do you need everything? So it's basically to do with intraocular surgery. It needs all the respect that you give to the intraocular surgery in humans. The same needs to be given in a canine surgery. So anesthesia consent has to be very, very precise and important. You have to convey that information to the owner themselves and take a death consent saying the dog might not survive the surgery or the anesthesia. Only phacoemulsification, I already said, there is no role of any other thing. Quick in and quick out. Why I say this is because no matter how good your surgery is, sometimes if you take more time, I have seen that at the end of surgery, you can actually see the inflammatory fibrils forming right in front of you in the OT. So that becomes quick in and quick out is of paramount importance. And then, of course, it's very important, the post-operative care and the caregiver. The caregiver has to understand why this is important. Fortunately, we've not had any issues with post-operative till date. Now, I have put a video. This is a post-op video. This is a dog called Siri. So you can see the dog is playing. Now, why I say clearing cataract, saving lives is this dog was blind bilateral mature cataract. It's an elderly dog and had attacked a couple of individuals unprovoked. It's a Rottweiler. So generally what happens if a dog turns like this, there's no other option for the owner but to put it down. So the owner had come to us saying, please do something for my dog. And this is the dog after we've operated on both the eyes, the dog is now back to playing, back to being itself. We have a similar condition. I think we call it blindness psychosis that happens in humans, probably happens in animals too. The dog was very anxious, was very aggressive because it could not see. And afterwards, it's fantastic. They're playing, and you can actually see the gratitude in the owner's face when they see their dog doing well. Thank you. So this is a photo of my dog. She's Ivy. Thank you.
Wonderful presentation. Yeah, that's crisp, clear. See, like you said, Bausch and Lomb doesn't supply intraocular lenses. Yeah. So where do you actually get the IOLs for your surgery?
Sir, when we started doing this, we found out that the dogs require about 40 diopters of IOL power. If you see, most of the companies stop at 35 diopters for human lenses. IOC is the one that goes up to 39 diopters. So initially, we put 39 diopters in the dogs. That worked out well. When I started ordering 39 diopters regularly, the IOC people asked me, why are you ordering 39 diopters so regularly? They found out I'm operating on dogs, and they've offered to make similar IOLs. So you can get those IOLs from IOC. So canine IOLs are now available from IOC. But Bausch and Lomb and there is another company, AGO, that specifically make only canine and feline IOLs, but they're not available in India.
So, what is the optic diameter? What is the overall diameter as such? Is it? You said the lens is big, right?
The lens is so basically the optic diameter varies from 6.5 millimeters and it goes up to 7.5, and in some cases in species like Great Dane, 8 millimeters of optic. And the total length of the lens varies from about say 12 millimeters to 14 millimeters. So that's the size of the lens.
Okay, so it's a big lens that you're implanting.
Yeah.
So what would be the incision size like? So it might require 2.5 millimeter or even more, right? For the foldable IOL to go inside.
Yeah.
It's bulky.
2.8. We have a dedicated machine for now these canine surgeries. That is the AMO older series. It had a 2.8. It requires a 2.8. So whatever IOLs have put till date, everything has gone through 2.8 very comfortably.
Oh, it goes through 2.8. It doesn't have to go beyond 3.
No, sir. So I've not operated a case of 8 millimeter optic dog yet requiring. Okay. That may require a 3 millimeter or 3.2, but the rest of them go through 2.8.
It's a single piece intraocular lens.
It's a single piece intraocular lens.
Okay. So do you actually give routine post-operative anti-glaucoma medications as such? You said you will check the intraocular pressure on first post-op day. Like, man, just like that, it might have. You said inflammation. And one more question. See, is there a point at giving subtenance triamcinolone? You said it induces a lot of inflammation. Because I mean, it can work both ways. Like there can be you can't actually check the intraocular pressure. There can be a steroid-induced IOP spikes. So have you tried? Did you ever think about?
No, sir. Subconjunctival we do give steroid at the end of surgery. But
no, that is dexamethasone, right?
Yeah,
Have you thought of giving triamcinolone long-acting? No.
No, sir. No, sir.
No. So post-operatively, you give tropicamide, then
atropine, sir. Tropicamide, atropine. Basically.
Okay.
Yeah.
Very good. And it's prednisolone acetate, right?
Yeah, prednisolone and an antibiotic combination.
Okay.
Generally, Abdrops, PDA, whatever, it's the same concentration as we use in humans is enough. Just it requires 1 hourly installation for 1 week, and after the first week, I've seen everything settles down, and then the journey towards the normal eye becomes smoother.
Okay, that's that's quite good. Like till now, how many would you have operated on?
I think it's about 30, sir.
Okay, that's quite good. Have you tried on other animals?
No, I've had invitations to operate on a horse, but I have not. But as I said, the OT.
You will ride the horse and operate, or?
So it came through a relative of somebody I had operated their dog on, and the horse, but there's no OTs that I can go to. I said, if the OT infrastructure is not as good as what we generally have, I'm not going to operate, because it's very difficult to, if it goes into endophthalmitis and everything, sir. Generally, what happens in these animals is these animals are put down. And so I don't want that on my conscience. So I refuse to operate outside the OT.
So, but even when they're blind, they're put down, right? So there is.
Yeah.
Why not give it a try?
Yeah,
sir. Yeah. I should give it a try.
Yes.
Yeah.
So,
Okay.
Srini,
Yes.
can I?
Yeah. Yes, sir.
So
Yes,
Srini asked a lot of academic questions. I'm going to ask financial questions. Obviously, how much do you charge for them?
Sir, so we charge about 25,000 per eye, sir.
Okay, and the anesthesiologist?
No, the veterinary charges are different. That depends on how much time it requires, what is the condition of the dog, and how elderly the dog is, what is the risk they're taking. They vary their charges. So they'll charge anywhere from 3,000 to 5,000 per case.
Yeah, that's reasonable. That's reasonable for a general anesthesia. Well, so 25,000, fine. And that is in Miraj. So in Ahmedabad, I can try about 40,000.
Yeah.
And doctors in Bombay and Delhi can charge even 1 lakh rupees.
Yeah.
Great. So now I'm interested.
So what is the status of the dog post ketamine and Sally? They're quite still, right?
Yeah, so that was surprising to me, sir, because initially, whatever literature for the initial cases that I had to go through a lot of literature, everywhere it said you have to intubate the dog and halothane and everything needs to be there. Unfortunately, we don't have the necessary skill here in the place that I practice in, wherein they're not ready to intubate any kind of animal. They said we can manage the dogs on ketamine, which they have been doing even for major surgeries. So I was skeptical initially, but it so turns out that it's good enough if they have their specialized monitors that they get, and they're monitoring the heart rate and everything intraoperatively also, and they're adjusting the doses of ketamine. So ketamine works fantastically. There's absolutely nothing else that is required. And the thing is, once the surgery is complete, and depending on the size of the dog, my staff has cleared the OT. The dog can be brought out of anesthesia and it walks out, which is amazing.
Oh.
Yeah. So this Rottweiler was one wherein we said we're not taking any chances, because Rottweilers are extremely aggressive and they're very powerful also. Yeah. So that's why I said if it's a small dog, people are not very concerned. But Rottweilers, you saw the photographs wherein there are a lot of the funny thing is most of my consultants, my fellows, and my DNB students, they're all crowd for this dog surgery. I've never seen so much interest in academics anywhere else in the institute. But dog surgery is everybody. Nobody's ill. Nobody has any other work. Everybody will come for that dog surgery. So yeah, it's quite an event when we operate on dogs.
Maybe
so probably by next week we'll have 10,000.
Your residents feel that there is not yet much competition in the field.
Absolutely. Shivu, that's my talk. Shivu, hold on, that's my talk.
Actually, Tejas asked the exact question I had in mind. How much you are charging for this?
Yeah.
25,000 seems to be quite reasonable for the amount of risk that you are taking. So definitely. And are you, maybe I missed it in your talk, but are you doing bilateral at the same time, or?
No, sir. No.
Not yet.
That is something we don't do, sir, because as I said, there's a very real chance of lens-induced uveitis. So this lens-induced uveitis in dogs is very notorious for not responding to anything. It's a refractive kind of uveitis where it doesn't respond to topical steroids. It doesn't respond to anything. Fortunately, I've not faced it, but I've read it in their literature. It does happen, and then you are in a soup if you've operated bilateral. So
And how do you take that consent?
From the
sir,
dog. He'll
The
wag the
paw.
tail.
The paw.
no, I'll tell you my experience of this. It's generally the younger generation in the house that wants the surgery, and it's generally their mother who's actually feeding the dog and taking care of the dog is a bit apprehensive about the surgery. So the younger generation wants that the dog to see. They can't really. They're not happy seeing the dog bumping into things and not being able to do things. But their mother is the one who will say कि जैसा है तो he's there still. Why are you taking death consent? What is the need? That happens. So we do explain about this video that I showed you. That helps. I tell them what is possible if they take that risk. What is possible? So
Yeah. I mean, just one other doubt. Like, see, when you operate cataracts, we mostly do with very senior citizens, and
Yeah.
most of them they have comorbidities. So dogs also, I think, must be a little older dogs which do
Yes.
get cataracts.
Yes.
So, do you screen them for other comorbidities, like cardiac issues, renal issues?
We do, sir. Basically, I'll tell you what I have seen. Most of these dogs are diabetic, and and what happens is they develop cataracts. They develop it very rapidly, and then if they are not treated initially in when they have had cataract, as the days pass on, they do also have renal complications of diabetes. So once the dog goes into renal complications, then giving anesthesia, everything becomes very risky. I've generally avoided that segment. But if what happens is the dogs generally come from the veterinary surgeons themselves, who's going to give the anesthesia. They practice we have in my place, the advantage is we have a huge government veterinary hospital, which is about a kilometer from where I practice. So all these doctors are highly competent in everything that they're doing. So the docs come from there, and they know that I will not operate on dogs who are in chronic renal failure or who have scissors. There are a lot of breeds that have a lot of neurological issues. So so only diabetes that has caused this cataracts we operate. It is safer. And one interesting thing I've seen, sir, it might be selection bias on my part, but the Indies, the street dogs as you call them, they're actually the breed is called Indies. I've not seen an Indie with a cataract. It's probably people don't adopt Indies that much, or they're not willing to spend money on Indies. But might be my observational bias. But it is these exotic breeds that people are into, which have these problems more.
Amey, there are
also
a
because
few...
of the inbreeding, a lot of inbreeding in the exotic species.
Yeah.
Whereas street dogs, they crossbreed a lot.
Yeah.
So probably that's why they also, I'm just thinking, because they want to maintain the pedigree. So there'll be a lot of inbreeding in the exotic species.
Amey, there are a few comments and queries on the chat box. So one is you explained that, but I'll maybe you can tell that again. So how do you do the biometry? You don't actually do a biometry. It's based on the dog's size, weight, and all, right?
Yeah. So basically, sir, like initially we had this, I think in humans also for biometry, people used to just put random aisles based on their experience. So right now, all the papers in the veterinary arena suggest that 40 to 42 diopters is where the IOL will work. The dog will have good vision. So 40 to 42 is the range, and it depends on the company that you are putting the IOL off. Like if you go for Bosch & Lomb, they'll have a 40 diopters. If you go for another KSOS or something, they have a 41 diopter IOL. So across only the size of the IOL is different with regards to the size of the dog. But if you take the dioptric power, every company has the same dioptric power, and it's true for feline lenses also. There are some feline lenses that they've come up with. For cats, I think it's about 48 diopters that everybody puts. And there are papers available online which show that 40 to 42 diopters is the range. I think you're muted, sir. Srini sir, you're muted. I can't hear you.
Okay, like there is a request from Dr. Meenu Chaudhary from Nepal. Can you share your email ID from Nepal?
Definitely. I'll do
Yeah.
that.
Okay.
And anybody who wants to come attend is welcome. We'll send you a date when we post canine surgeries.
Yeah, a fellowship in post canine surgery.
Yeah, sir.
A fellowship. So you can start a fellowship.
So this is a wonderful. Like one last query: what if PCR occurs?
Yeah, sir. I think something. If we operate on these dogs at a later stage, when they are 6 months into having a mature cataract, 1 year into having it, because the owners generally don't take decisions fast because of the consent that we take. We see a lot of dogs with calcified capsules. The posterior capsule itself is calcified, and there are opacities while we are operating. So I know we had this discussion in Goa where you suggested I should do a primary capsulorhexis, but I have not tried that yet. So I think the next dog I have, we'll try a primary posterior capsulorhexis to avoid that. But right now, if a dog develops PCO, there's no treatment that comes to my mind. You can't laser the dog. So I think your suggestion back in Goa was brilliant. You should do a primary posterior capsulorhexis. I am a bit hesitant because I don't know how the posterior capsule will react to surgery. I have not had a rent touchwood in any of these cases till date, but we'll try it in the next case.
It could be a different form of inflammation also. You do not know how it works and all that stuff.
Yeah. And I've set
but
up.
But touching the PC per se is not going to create an inflammation. It's the iris that should be causing inflammation. PC should be okay, right?
The compartments, if the compartmentalization is taken away, I think if the inflammatory mediators go posteriorly, we're not very sure what happens then.
Maybe you could also try, using a vitrector to make an opening, what the size that we would do with a YAG. Okay. Not go for a large rhexis, maybe just about the size of a YAG opening can be done with a vitrector.
Then you will have to charge 50,000 rupees because that's another surgery. Using a vitrector, a probe will also cost.
Sir will always finally end up in the finance aspect of it. And Ameya, your hospital website will be
dranilkulkarni.com.
Okay. Dr. Meenu, if you go to dranilkulkarni.com, you'll find all the details, contact for Ameya, and Ameya will be always ready to help you. Thanks a lot, Ameya. It was really wonderful. So quite a good interest on YouTube there. I've not had this much discussion on the chat discussion during any of the other scientific presentations. Really wonderful. Thanks a lot, Ameya. You spoke really well.
There are a lot of dog lovers, sir. So.
Yeah. I was talking to Dr. Srikanth, who's a avid dog lover, and he used to have a dog, big dog, when he was in Shankara. Shankara is a vegetarian campus. So that's a lot of dog lovers and a lot of interest in your talk. I'm really happy that you gave this talk. Thanks a lot. And now another one that is going to be really interesting is the talk from Dr. Tejas Shah. Sir, see, it is I mean, one of the most lovable persons that you will ever meet. Like, he's always really open to any discussion as such, and his practice in Ahmedabad is the oldest surviving group practice in ophthalmology, as well as a neutral surgical center. And it was first established by Dr. Tejas Shah. And so that's what I'm like. He's always ready to help people, and he's one of the initiators of the SSTC and AOC meetings, and is a representative of AOS committee reforms in NABH, and chairman scientific committee of Gujarat Ophthalmic Society for 6 years, member scientific committee of AOS for 6 years, and as I said, his real hobby is making money and traveling. Over to you, sir.
Thank you, Srini. And first of all, at the outset, let me thank you for inviting me. Well, as you know, this was all produced, or I would say conceived in Goa with you, me, and Amya there. Great. So let me ask a question to all the ophthalmologists. What is our bread and butter? And it is also a big bane to us. That is actually trying to counsel and convince, which is one surgery where we need all these things, and that is a cataract surgery. Correct? Because
Yes,
somehow cataract surgery for all the patients, all the laymen is only one. They only want to talk about lens, and lens. They have nothing else to discuss with us. They just want to say, "Kaun sa lens daloge? Ye lens kitne ka hai?" So since I was going to talk about some value-added tips for your cataract surgery, I thought let me share with you what we actually do to counsel them.
sir, can you make it full screen?
It is full screen for me.
It is not full screen here.
It's
So
not full screen here.
my son says it has to be pinned. He's 8 years. I don't know.
Just a minute. To me, it is full screen, but it's not moving. So let me pause and try.
So you can unshare it and open it and try sharing it again.
Yes, that's what I'm doing. Direct. Yeah, sorry for that. Oh.
So before sharing, why don't you now unshare, then open the presentation and then share.
Okay.
Unshare now.
Stop sharing, correct?
Stop share now.
Yeah.
Open.
The presentation is open.
Yeah. Now.
Should I make it full screen before that?
No, you could do that, but that'll be difficult. If you can do that, that'd be good. Now you just share. Let's see what happens.
Yeah.
If it doesn't work, I'll tell you what to do.
Yes. Is it okay now? Is it okay now? Can you see, Srini? I cannot hear you.
See, now it's not full screen for us. Just leave it at that. Actually, you won't require slides for it. But anyway, you go to the left, see 1, 2, 3 slides. Now you pick up from there. So now it is slide number 1. Go to the left and pick up the second slide.
No, but it's full screen for me.
Yeah, I know that's it's not you're not shared it perfectly, but now let's not waste time.
Yeah, sure.
So go to the left where all the slides are there. From there you pick the slides, like you go to slide number 2, 3.
No, I understand, but for me it is full screen now, so I will have to come out again and then do it.
Yeah.
Is it now okay?
No, you're not sharing now.
Okay, I'll share now. Is it full screen now?
Yeah, it is full screen. Perfect.
Okay, great. Sorry for all that confusion. A long time and no Zoom, so I've forgotten everything. Okay, so our bread and butter is of course cataract, but it's also a big bane to actually counsel and convince, because everybody feels that it is only the lens that we. I cannot forward it. Oh man, what's it? Somehow I cannot forward it. Yeah, okay, I got it. Yes. So we have this small. We have made this small A4 size menu, you can say, and we do not talk anywhere or anything about lens. We only talk about technology. So, for example, we have monofocal technology, and we try to tell the patients that this is one technology where you will have at least 2 to 2.5 diopters of refraction, 100%. Because when you put a monofocal lens, you can either get plus 2.5 for reading or minus 2.5 reading or something in between. And there we also show them that we have the small, the ECC, which is 50,000 rupees, the small incision, which is 22,000 rupees, and all our micro-incisional techniques, they cost from 30,000. Now, still the patient keeps on asking you about the lens kaun sa hoga isme. So we said, please wait, we are coming to that part, because the lens comes every 30 seconds, the lens will come in between. So then we said that, okay, so this is one technology, because lens is not the only part of the surgery. For me, the lens is only 5% of the entire surgery. For example, it takes me 70 minutes to actually plan your surgery, which includes which implant to be implanted, while it takes only 7 minutes for me to do the surgery. So please understand that let's start concentrating on what we actually want to do, which technology we want to offer to you. Then the next category is, okay, you don't want to wear so much, such a huge number. Well, you try and go for intermediate technology, where you might have about 1.5 diopters of lens of spectacle correction, and it will cost you, for Indian intermediate technologies, of 40,000, and for import it will cost you 57,000. Then we also have the toric component. So we always try to tell them that this we will not discuss before we do the sonography, right? Then we say that we also have the multifocal, and then we also say that we have the femto or the robotic surgery. Of course, the terminology robotic is always there, and we add 45,000 for the femto technique to any of the above packages. Now, the patients usually in Ahmedabad go shopping, and when they actually go shopping, we actually want to not give them everything, but still not scare them. So what do we do next? We say that, okay, you want very specific answers. I need very specific. I will need very specific investigation for you to talk about your particular eye. Both the eyes are different. We have this cataract summary by NIDEC. It is a very nice OPD scan, specular microscope, and an optical biometer. So we say that, okay, here, if you look here, we have the first and the second choice of the lenses. So the problem is there are a lot of patients who come, sir, panoptics dal do, sir, mere ko contour vision karwana hai. So we tell them that no, these are not your Zeiss or your Ray-Bans or your Essilor glasses. Here we can operate you only once. And so we go according to these very costly machines. And the costly machine will tell me the choice of the lens that I have to implant. Right? Even though I only manually put the choice, but this is how we try to take the patient away from the lens. So we tell them that, okay, let me do your sonography, because they take away a lot of your chair time and you earn only the consulting fee. And we charge 2,000 rupees for this sonography. So the patient is also sometimes reluctant. If the patient is reluctant, we say, okay, we will deduct this 2,000 rupees if you get the surgery done by us. So at least at the end of the day, after spending some 15-20 minutes, we have earned 3,000 rupees from the patient if the patient does not come back for the surgery. So this is how we try to actually counsel and convince without getting irritated, and also we get some money out of it. If the patient does not add an optical biometry and this entire cataract summary done with us, we say that we cannot answer you. The counselor will answer all the questions. So this is how we try to not scare the patient. We try to counsel the patient and also not sell ourselves. Then the next question is, do you do a robotic surgery? So we have a small video which we show them. Why should I pay for a robotic surgery? Very recently, somebody sent a message. Somebody sent a nice joke. Sir, aapne robotic surgery kiya, then why do you charge for surgeon's charge? Right? So that is why we show them this video. It's a very small video because we have to actually tell them what is different with a femto surgery. So we just show them this small video, which is about 15 seconds. And then we try to tell them, just look at the perfect circle. Just look at the perfect cleavages. They are so perfect, textbook-like, mathematical precision. And that is what you pay for when you actually do a robotic surgery. And then we also show them that it is not purely a robotic surgery. We also do some manual things. And we also show them this particular picture of how perfect the capsule axis is. So these were a few, and okay. Then we also show them the manual surgery. So usually the discussion goes to, can you draw a perfect round with your hand? Well, the patient says no. We say, can you draw a perfect line with your hand? The patient says no. So we say that all this is done by the femto laser, and that's why you have to pay for this luxury. But yes, there is safety because your eye is locked during the entire procedure. the important steps, not entire, but the important steps of the procedure, and it does not involve any important step which is to be done manually, just like we are doing in a phacoemulsification. And we have been very successful using this kind of tools in convincing our patients and not letting them go. And so I thought, let me share this with you as my value-added addition to our cataract surgery counseling. Well, when a patient comes to us these days, what do? We try to do an OCT, we try to do a perimetry, we also try to give them anti-VEGFs, we try to do the LipiFlow. Well, these are the ways we try to get the best out of the patient, right? I'm actually saying best out of the patient. But frankly, we are all Arjuns. Now, don't be flattered when I say Arjun. Why? Because Arjun kept on looking at the eye of the fish and he got Draupadi, right? But when we also keep on looking only at the eye, we only get dilution because we have not diversified. Now, what do I mean by dilution? Dilution means day by day, the number of cataract surgeons or the ophthalmologists are increasing. And in fact, our population is not increasing at the same rate. So we felt that actually we are going to end up not having many human patients for us. And probably Ameya heard my presentation that we might have to keep on doing cats and dogs. We might have to do other surgeries because we actually want to do a value addition towards surgery. During a lot of friends that tell me, sir, how to scale up our practice? Well, I said, think about diversifying. And that's how this entire presentation has come up. Why why do we remove only spectacles and glasses? Remove pimples and wrinkles also. Well, let's understand what I mean by this. When we get a patient for our ophthalmology, right? The patient is usually accompanied by one or probably two or sometimes even more persons. And these are the persons who just walk into a clinic, they use your facilities and they go home without paying you anything, right? But why not think out of the box and try and rope this attendance, I would say, also along with the patient. The patient who trusts you for his eye is also going to trust, and his relatives or her relatives are also going to trust you for some other things. A female patient might need a lot of more services than just besides a LASIK, correct? So rather than going to cats and dogs, Ameya, we can also diversify in something different, and that is try and offer them some different services, right? Think out of the box. We keep on doing the laser surgery on the eye, inside the eye. Why not do it besides the eye also? And that's the whole thing that can add a lot of value. It can scale up your practice, correct? Right? Why to remove only glasses and cataracts? You can definitely think of removing pimples. You can definitely think of doing under eye dark circles, wrinkles, cellulite, unwanted hair. All these treatments are these days done by dermatologists and cosmetologists, but they've also been started. They are offered by the beauty parlors. If beauty parlors can do it, why also we cannot think about it? So the biggest question is, how and why am I going to do this? Do I need a subspecialty? Do I need a fellowship? Do I need to do a lot of training? Well, so the questions are, do we need any fellowships? Do we need to do treatments ourselves? Do we need a big investment? Do we need a new clinic or employ more people? Will it eat away a lot of your ophthalmic time? Well, the answer is a big no. But it will add value and definitely the greenbacks to your practice, and the answer is big yes. Right? Let's understand how. Let me give you the example of an excimer laser. Right? An excimer laser, well, these are old slides, 7 or 8 years. This presentation I had made before 8-10 years when the excimer laser was costing 2 to 2.5 CR. Now it is 3.5 CR. I'm talking about the excimer laser versus the silk skin concept. The silk skin cosmetology clinic is our own brainchild. My wife is a dermatologist. So the investment could be about 3.5 crores these days, while in a silk skin concept, it can be on a subscription basis and it could be as low as 5 to 10 lakhs also. Right? What is a per procedure consumable for an excimer laser? I'm just talking about an excimer with a blade. It could be somewhere around 6 to 8,000 with the blade and the gas. For the silk skin concept, the per procedure consumables are very negligible, minuscule, in hundreds, and so I've not mentioned them. What is the maintenance of an excimer laser? About 20 lakhs per annum these days. Well, for the silk skin concept, it is all built up. The CMC is built up into the silk skin concept. The time required for an excimer laser is 15 to 60 minutes, which I'm also including the convincing and the counseling. But for a silk skin concept, it's only a few minutes, and in fact, after some time, not even few minutes, because it keeps on happening. What is a risk? You all know what a potential risk can be an excimer laser, of course, right? Well, with a silk skin concept, there is hardly any risk. The maximum risk is the patient might say, I did not like your treatment. Well, you can give the money back and the patient walks out very happy. We cannot do that with a keratoconus patient, right? And what is the earning of an excimer laser? About 20 to 40,000 rupees. Well, for a silk skin concept, the earning is 2,500 to 4,000 per sitting. I believe somebody in your family might have got such treatments done. And the biggest advantage is no mediclaim, no paperwork, and this is all a cash rich treatments, right? So I hope all this definitely makes you feel that you should start thinking about it, right? This is one of the companies which we promote. This is a very expensive company now. It's a Canada-based company. Now we have Indian products also available, right? At that time, we used to offer this kind of subscription model, though they are now revised. So the prices have gone up, but also the price per treatment has also gone up. Like this particular machine, it can do a lot of circumference reduction, improving cellulite, skin tightening, also reduces the appearance of the wrinkles. Right? So there are a lot of such these machines which can be sitting besides your autoref. They are only the size of your mid-sized phacoemulsification. You can always keep them in one corner of your OPD and use them when you have gone for surgery. And who's going to use it? Well, your qualified nurse also can use them, right? These are different models. Right? Who all will be your customers? I'm saying customers and not patients. Well, the young, the middle-aged, and the elderly. Imagine only one person has filled up your registration for the eye. And if you offer all these treatments, how do you offer them? You just put up a few posters in your clinic. That's more than enough. Start slowly. You don't need to put up billboards for all these dermatological treatments. You better not, because you start slow. And only cater to the patients who have walked into your door or their relatives. And this will become a very, very easy way of adding value to your patients. If you need any help, this is my cell phone number and this is my email ID also. I would call it as a side business. Why? Because a side business means you do a new startup, you improve and improvise, you diversify and you expand. And I would definitely call it as a side business, which sometimes it can also become your main business. Sometimes you might even be more successful with all these things. Every now and then for our LASIK patients, we get a inquiry, sir, when can I do hydrofacial? So we can always say, I will do the hydrofacial and then do the LASIK. I can do your photofacial and then I can do your LASIK. I can do hair removal, I can do your eyebrow shaping, I can do your beard shaping, or I can do your hair removal. And I will be more careful because I know what is to be done. So this becomes a very important message. Can we as an ophthalm do all these things? How to market, training, don't have time, legal complications? These are the frequently asked questions. I'm not going to answer them now. If you are interested, you can definitely get in touch with me and I will actually tell you more. In fact, we can also send a team to your clinic to do a recce and suggest what type of machines you should buy and what type of treatments you should cater to, depending upon your geographical location and the type of clientele you have. And the most important slide, ladies and gentlemen, I am also contesting for the post of joint secretary, and I would definitely like to have support from all the EIS members. Thank you very much for listening, and I hope you have a lot of ideas, and I get a lot of phone calls or emails. That's the end of the presentation, Srini.
Dr. Tejas, see, I understand. Can you please unshare? See,
Yes,
I understand that we all know that all these barbers, the beauticians, everyone are doing this stuff. I totally agree. But when it comes to a medicine man doing this, I as an ophthalmologist doing this, and would there be any resistance from the qualified dermatologist?
Yes and no.
And how do you how do you go about it? Because the complaint will be to the IMA and all those people. See, maybe like legally it might be okay. See, everyone is doing it as a minor procedure. You can do it because you have MBBS. You can do it, and per se, no complications as such. But how do we handle
Absolutely.
the resistance from dermatologists, because we are actually straying into their territory?
Yes, very true. Now let me rephrase. Let me take you back to all the statements which I have already made. I said don't put up billboards. I said this you offer inside your clinic. The patient, when he walks into your clinic, there only will say poster that we also offer laser photofacial, right? So that is one way you are only trying to latch on to the patients who have walked into your clinic. Number one, but still the dermatologist could be annoyed. What do they do if they're annoyed with the opticians, or what do they do if they're annoyed with the beauty parlors? Well, they can hardly do much. So the second thing is you can definitely try and employ a dermatologist and put them on board with you, right? Yes, and you said as an ophthalmologist, we do not do the treatment. We offer this treatment. So there is a big difference between you doing the treatment and you offering the treatment. But yes, all your questions are very valid, and you have to take it by the year, and you have to take it according to your geographical location, because you are not trying to latch on to the patients who are walking on the streets. You're only trying to offer this treatment to a patient. You know, we get a lot of complaints. Sir, you removed my glasses and now my under eye dark circles have become very prominent. Well, we all know that they were hidden behind the glasses. So all these things can actually be taken care of. And like I said, you don't go all guns blazing. Offer them only a couple of, don't we do Botox? Right? Botox is also basically a cosmetologist procedure. We might do it for blepharospasm, but once you start doing it for blepharospasm, a lot of patients come for other things also. So yes, this is transgressing into their field. My wife doesn't like this when I give this presentation. She's a dermatologist. But well, I say that you can definitely scale up your practice to your patients, because these are your patients who have come to you. And you can always say that rather than going to a beauty parlor for a laser photo, which is usually a chemical photofacial, they cannot offer a laser photofacial, right? They come with burns and all that stuff. So this is my explanation. But yes, there are quite a few loose ends. You actually need to do it once you start seriously thinking about doing these procedures. Have I answered most of your questions?
Yeah. See, any questions, Dr. Shibu?
Yeah, Dr. Tejas, I am just curious only about one thing. How have your peers in your neighborhood taken to this?
I don't have a problem. My wife is a cosmetologist.
Okay.
So I have an in-house silk skin laser cosmetology clinic.
Yeah.
So for me, it is not a problem. I am trying to suggest this to pure ophthalmologists who have an OPD of 50-70 patients, and you have a footfall of about 150, correct? One patient, at least 1 or 2 attendants. And once they're sitting in your clinic and they see, oh, laser hair removal is also done in this clinic. Let me utilize this time and get my laser hair removal done on my face. And I forgot one important point. When you do a LASIK, the patient comes to you only once. When you do a photofacial, when you do a hair removal, the patient keeps on coming to you.
It's really interesting. I mean, you have opened up a new, way of thinking. As I was listening to your presentation, I was just sitting here and, thinking, this is such a great idea.
Sibu, this presentation was made 8 years back, and I have delivered it at least 50 to 60 times in different meetings, including Bombay. I think I had come to Cochin also for a Cochin Ophthalmic Society meeting. This was when Dr. NSD Raju was the president. At that time also I gave this. but there is a lot of resistance. I absolutely agree to that. There is a lot of resistance.
Okay. It's a different talk, Dr. Tejas.
Yeah.
Thanks a lot for that presentation. Now we'll move on to the presentation by Dr. Shibu Varki. See, I've known Dr. Shibu Varki for a long time. Like the first time I came to Kerala when I joined Chaitanya. I came from RP Center. I had gone to Shankara, and then from Shankara after the fellowship, I joined Chaitanya Expandam under KG Naisar. And so the first Drishti conference, he was there. Like, see, very commanding presence and wonderful presentations. And he was. See, we all talk about everything as such, like the revolution that the Vasanai care had brought to ophthalmology, and what it has done to ophthalmology as such. It's changed the way that everyone sees ophthalmology, and Dr. Shibu was one of the pioneers in that field, and so I have a great respect for him, and once I had heard him speak on cosmetic eye color change surgery, and I believe that he has done quite a few. So we would like to learn, hear from you. So when I asked Dr. Shibu if he would present on cosmetic eye color change surgery, he said, Srini, it might end up being not a recommendation as such, but it might be on a negative side that I might be presenting. But that's actually absolutely great. Like somebody talking about something, his experience, and see, he himself saying that he doesn't actually really perform that, and coming out and talking to us regarding this, because see, we all learn from all this. So whatever he has gone through during his the procedures as a surgeon who does cosmetic eye color change surgery, and probably he must be the person who must have done it the maximum numbers in the world. So Dr. Shibu, thanks a lot for joining us, and can you please start your presentation?
I hope my screen is visible.
Yeah, visible,
yeah.
Full screen.
Yeah, thanks a lot, Srini, for giving me this opportunity and this invitation. And I also thank Dr. Ameya and Dr. Tejas for their wonderful presentations. I think I have learned a lot from both of your presentations as well. To put things in a proper perspective, the first two presentations talked about what you can do or what you should do, and my presentation is probably about what you shouldn't do. And it's always, as they say, good to learn from others' experience rather than from your own. But I have learned from my own experience, and so this is what I'm going to talk to you today. And the screen is stuck. I'm just trying to move it. I think I have again the same problem as Dr. Tejas had.
Yeah. So just unshare.
I'll stop sharing. I'll stop sharing and share again.
Yeah. So the two ways to go about it: try making it full screen, or you can pick up the screen slide from the left.
Yeah. It's moving
perfect,
now.
Perfect.
So therapeutic iris processes. There are basically two. Cosmetic. Therapeutic iris processes has been in use from the 1950s, and the main indications being traumatic iris defects, congenital aniridia, iris coloboma, surgical iris loss, ocular albinism, and so on and so forth. And the therapeutic prosthetic iris devices, basically they are two types. One is the iris lens diaphragm type. The other is the endocapsular tension ring type, which has got fins. And now the latest one is the customized artificial iris, which is the custom flex from Human Optics. The first implant was done in 1956 by Dr. Choice. The main difference between therapeutic versus the cosmetic one, which I was using, is that the therapeutic is, as I said earlier, is either sulcus or endocapsular fixation, whereas the cosmetic one, which is available now, it is an angle fixation type in the anterior chamber. I started my journey about using iris processes with the Morcher device. I first used this device about 20 years ago, and it was used for congenital aniridia. A family of 3 children, all 3 of them with congenital aniridia. So I was on a lookout on what is available. At that time, what was available was the Morcher device. This device, it is a combined IOL and iris prosthesis, and it is of a PMMA material, and it is available in 11.5, 12.5, and 13.5 haptic to haptic diameter. And it has also got suture holes on the haptic where you can even scleral fixate it. And so you either endocapsular fixation or a scleral fixation using sutures. And it is available in various colors, but mostly in the ones that I used were of black pigment, because in our Indian population, that's what most of the people wanted. And I have a follow-up of them of nearly 20 years. The children have grown up, and they are still maintaining good visual function and symptom-free of the problems of aniridia, though few of them did need glaucoma filtration surgeries about 5 to 6 years after the implantation of the Morcher device. The Morcher device sadly is not available in market. So that is how I strayed to the device. You can see those black ones over there. So when the Morcher device is from a company called Bright Ocular. So as I read more and more about Bright Ocular, I found that preceding them, there was another company called New Color Iris based in Panama. And the Bright Ocular implants, the New Color Iris implants had a lot of complications. And so the Bright Ocular, they have alleged that they have made some developments over the New Color Iris. As you can see, the New Color Iris, the blue one, which is on the left side, it is plain. It is just plain silicon material. Whereas on the Bright Ocular, they have introduced certain grooves. And these grooves, they thought will help in the drainage of aqueous, which will not produce a blockage of the aqueous circulation it is groove on one side and ridge on the other. So the ridge will give a kind of elevation from the iris surface and allow the aqueous to drain under. That was the concept. But when I started using them in 2012, there weren't much of a follow-up or long-term studies. It is not yet or US FDA approved, and it is used. It is not allowed in the US. So for this procedure, actually at that time, I was the only person from India. There were a couple of other doctors from Jordan and some other countries. So we did meet together in the sidelines of the ESCRS in 2012, and we ourselves said, okay, this is some of the guidelines that we should select for selecting patients for the procedure. So AC depth of 3 millimeters or more, gonoscopy 30 degrees or more of open angle, endothelial cell counts of 2000 or more, white to white diameter not less than 11 mm, and no other ocular comorbidity. So these were some of the criteria that we agreed upon in selecting the patients for this procedure. The company which is manufacturing the product, they had their own very strong social marketing, social media marketing, through which they would send patients to us for surgeries according to the patient's choice. So there was myself from India, there was a doctor from Jordan, another from Tunisia, and then a couple of other doctors from other countries, which I don't exactly remember this point. So initially, I used it for aniridia. I was not yet bold enough to venture into putting it into a normal eye. So this is just showing you a video about usage in aniridia. Sini, I hope the video is playing and visible.
Yeah, it's visible, playing.
Yeah. So in this case of congenital aniridia, I have done a refractive lens exchange and replaced it with a IOL. Because of the aniridia, there is lack of support for the implant. So the IOL kind of gives a posterior support so that the implant would not, fall into the vitreous cavity. This is after that I started moving into the area of cosmetic iris surgery. Sorry. I'm sorry for that. I'll just this is how the procedure is done. I'm using a 2 mm 2.2 mm keratome.
Can't see the video.
Incision. Yeah, I will, and I will fast forward. I will just show some of the relevant portions only. The pupil is. Beg your pardon?
No. The video is not seen.
Video is not seen.
No. The screen says this video is age restricted and only available on YouTube. That's it.
Oh, I'm sorry. Okay, then I'll just skip over that.
Yeah.
Okay, I'm sorry I couldn't show you the video, but anyway, so many of them, in fact. View a breakup of some of the surgery because these were people who were in their presbyopic age groups who wanted to have their refraction also corrected. So it was done with multifocal IOLs. It was done with accommodative IOLs. And then about 22 eyes, I had combined it with LASIK, and in 2 eyes, squint surgery was done along with that. Now, about 3 years down the line, patients started reporting complications like chronic iritis. That was the most common problem that was noticed. There was a very indolent and persistent UVA iritis, which would respond to steroids, and patients had to be on steroids for a very long time. In many of these patients, they showed a creeping angle closure, secondary glaucoma, endothelial damage, and so about 3 to 5 years, additional procedures were needed in several of the eyes. Glaucoma procedures of various types were done in about 18 eyes. 3 eyes needed keratoplasty. About 24 eyes, the implant had to be explanted and removed, and cataract surgery had to be done in 6 eyes. So looking at these kind of complications, because most of these patients, they have been from other countries, difficult for them to come back again and again to India for treatment. Many of them are refused treatment in their own countries for having undergone an unaccepted at all. But then there is still a huge demand for this. The very interesting observation that I could make is that even in spite of these complications, none of the people were willing at up front for an explantation. They needed a lot of cajoling and a lot of explanation and warning for them to accept an explantation, because it had transformed their personality so much that they didn't want to give it up. Some anecdotal success tales. These are 2 of my very early patients. One is in India and the other is in US. Incidentally, both of them still maintain healthy corneas, normal IOPs, and no intraocular complications at all. So I was just looking at their case sheets and I found that both of them had like 3.75 plus ACD and huge cell count of 3000. This guy on the right side, he is a rock star, and also now he's changed tack and green. So he recently contacted me saying he wants to change the color again. Medical student, you yourself need to take stock of the situation, understand the complications, and stop. But then both these people are doing absolutely fine as of now, and so probably the AC depth and their extremely high cell counts are giving them this kind of protection. As I was showing you in the previous slide, the creeping angle closure seems to be the root of the problem. There are patients whom we have done iris claw lenses, excuse me, with follow-up like 15 years and more, who still are quite fine. They have this, this is a silicone implant, but that is, a PMMA implant, which is on the anterior chamber and staying there on the iris, but they are doing fine. And so when I think about that, I think probably the issue here is not the implant itself, but the location of its placement, which impinges the angle 360 degrees. So maybe there is a room for modification of the model. Maybe there is a room for rethinking the selection criteria. And if at all that is possible, maybe the procedure may see a resurrection. So what is the future? Now we have uh, a new development coming up, which is a laser eye color change. I had the opportunity to try out the prototype of that equipment myself on a couple of patients. It is a long process. It is not a one-shot simple solution like an implant. In implant, you do it once and it is done. Laser eye color change would need at least 4 to 6 or even more sittings, where you can actually, because the iris pigments are not like a plastic bag filled with pigment. You make a hole and the pigments leak out. The melanin is actually incorporated in the fibers of the iris stroma. So you have to really use the laser to disrupt some of the fibers so that the pigments get released. So of course you cannot give the range of color choices as you would give with an implant, but then still some kind of lightening of the iris is definitely possible. But then the long-term complications of releasing that amount of pigment into the eye needs to be studied, and its long-term complications need to be studied. The other one, as I was telling, is will an iris clip model of this implant work? Will it be safe? That's something that needs to be looked at. In summary, I would say that definitely no, it's not a safe procedure. There are a lot of long-term complications, and it can lead to irreversible vision loss. So as of today, using prosthetic devices for cosmetic purposes, definitely I will not recommend. Thank you so much for your patient listening, and we can discuss. Thank you, Srini.
Thank you, sir. See, why did all these people see what? Do you find anything common in the personality trait of these people who did come for this iris color change surgery? Because I've seen one of these people in because it's totally different looking. In America Got Talent, one of the singers who came for the audition, I saw that it's a stunning look, like that iris color there. But what do you think was the common personality trait that was there among all these people who came to you for this particular procedure?
Among the people who came to me, one group are people who have a different color compared to their other family members. So I had people, they were mainly of Caucasian and Middle East mix. Most of their family members would have light iris, whereas they would have dark iris. So that was one large segment of people, immigrants from Middle East to the Western countries, mixing with the local population and feeling that they are out of place because of their the color of their iris first. The second group of people were people who felt that by having lighter iris, they have a better chance in show business, like singers, actors, aspiring actors, people who thought that having lighter iris would give them a better chance in the show business. Then, of course, as I said, there were people with albinism and then a few cases of traumatic aniridia. But cosmetic, basically, these were the two groups of people who came. And regarding their personality trait, yes, I want to tell you, I agree with you. They did have a lot of insecurities. They had a lot of complexes. And as an anecdote, I should say that there was one particular patient whom I had to literally bring home because of the difficulty in handling a foreigner in an unknown location in a new place. Post-operative management, I literally had to bring that patient home, and my family had to take care of that patient till the person was fit enough to return. It was beyond the handling of the hospital. So there have been people with this kind of complicated psychologies. Yes.
And see, for those who develop glaucoma, so in all those cases, was the IOL explanted and trabeculectomy or some other procedure done to control the intraocular pressure, or just removing the IOL and putting them on anti-glaucoma medications really helped, or did all of them require surgery?
Yeah, no. Just by the time they developed glaucoma, there was significant angle closure. So just removing the implant would not work. Ciliary body to reduce the pressure.
Sir,
Respective procedure had to be done in a.
Yeah, can you please turn off your video, because I think your this thing is your net is okay. Now you can answer, sir, because we were losing you in between.
Okay. By the time the patient's glaucoma was detected, there was significant closure of the angle. So just removing the implant alone did not control the IOP. Is it clear? Am I clear?
Yeah. Absolutely.
Yeah. So removal of the.
Frankly, Srini, Dr. Shibu already said that he would not recommend.
Was essential.
So I believe that.
Fine. That's absolutely fine. Like if you have to see these sort of advances, see like that, sir said, there are new procedures coming in for iris color stage surgery. So we should all learn from whatever has happened. So like sir said, a new implant might come, which might be there on iris. So we would like to know what happened through all those, so that in case something like that comes to the market, how should we go about it? So that's just that. Ameya, please.
Yeah, fantastic presentation, sir. I would like to know, you said you wouldn't recommend it, but if you have to, we lost him? I think we lost him. Yeah, I just wanted to know his parameters when he would operate. For like he said, the AC depth one, the endothelial cell count. What else does he look at if he has to operate?
Ameya, see, I don't think anybody is going to work with the similar type of a lens, because the first thing he said when I asked him to speak on this, because I knew that there are complications which have even come to a few of my colleagues, but I didn't know that it was the extent was this much. So he was kind enough to come and talk and explain about that. That's great. Like if something like that comes, say we should always be careful when we go about with some new procedures and all. So that's absolutely wonderful. And overall, like we had a different day today. Started with Ameya. Yours was the most probably had the, like I was just following the viewership in YouTube. So there are a lot of dog lovers among ophthalmologists. That's absolutely clear about it, and sure that you stand for the elections. All these dog lovers vote for you, Ameya.
The election is your business. I'm just here to operate.
Yeah. So, Dr. Tejas, it's wonderful to hear from you. Different perspective of practice. So we have a few seniors in Kerala who does this sort of you can call it offbeat sort of a practice. It's nice to learn from the experiences of seniors who've really succeeded in doing all this. And thanks a lot, Tejas. Sir, you're there?
Yes, I'm there. I'm there. Just
Yeah,
that my
yeah,
video is on. I'm driving, going
Yeah.
home.
Yeah. Okay. Okay. Now,
Not a problem.
thanks a lot.
I want to make one comment. This is not an offbeat uh, recommendation that I've made. If you actually think about it, sleep on it for a week, talk to me for a couple of days, you will feel that this is something which you should be doing.
Yeah, I agree with you, sir. But it's that mind block and everything is always there for us.
Yes,
Like
yes.
you're straying into somebody else's territory, sort of.
Yes, that is always there. That is always there.
Yeah, like so you can have the periocular. You can
Rejuvenation.
you stay in the periocular area.
Yes, exactly. Because we will only do these procedures in the area around the eyes. That's what I said to begin with.
Yeah, so that should be fine. Ameya, last comments from you, and then we'll.
No, I completely agree with Tejas, sir. Some of my friends who practice in the US, cataract surgery with blepharoplasty is now their #1 procedure that all of them are doing. So that blepharoplasty is basically for, I think, sagging of the eyelids and everything. So yeah, this will come eventually, and we'll all have to learn it and do it, is what I feel. Tejas sir, as usual, is about 15 to 20 years ahead of his time.
Yeah.
So, that is why, sir, you face that opposition.
Thank you. Yeah. Thank you for saying I'm always thinking old.
Thanks a lot, sir. Thank you, Ameya.
Thank you, sir.
It
was a pleasure.
Thank you.
Awesome, Ameya. See you soon. Bye-bye.
Thank you, sir.
See you soon. Bye-bye.